Hello and welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson and I'm one of the GPnotebook study group presenters. On this podcast, I'll be discussing mumps, not just as a classical childhood illness, but as a condition that still matters in our modern practice, particularly in specific populations and settings. Now, we've all been in that busy afternoon clinic when a young adult comes in with a few days of fever, headache, and that familiar viral feeling, poor appetite, a bit of myalgia. So far, so routine. But then you notice the swelling along their jawline, just in front of their ear, and that's when a diagnosis many of us associate with the past then comes back into play: mumps. So let's start by reminding ourselves what mumps is. It's an acute, systemic viral infection caused by a paramyxovirus. And while we tend to think of it as a disease of children, the epidemiology has actually shifted. And these days, we often see it in adolescents and young adults, especially in environments like universities where close contact is unavoidable. Now, spread occurs via respiratory droplets, direct contact, or contaminated fomites. And once someone is exposed, the virus has a relatively long incubation period, typically around 16 to 18 days, but it can range from about 12 to about 25. And that long window makes it harder to trace contacts and control spread. Because what makes mumps particularly tricky is its infectious profile. And patients are contagious before they even realize they're unwell. And viral shedding has actually been detected in saliva as early as 7 days before and until 9 days after the emergence of clinical symptoms. On top of that, around 15 to 20% of infections may actually be asymptomatic, particularly in children. But these individuals still transmit the virus. And this helps to explain why outbreaks can spread so easily. Now, before vaccination came along, mumps infection was almost a rite of passage in childhood. Most people were exposed to it early and developed lifelong immunity. And that's still largely true. Immunity after infection is generally long-lasting, but reinfection can occur in a small minority of cases. But the big game changer here was the introduction of the MMR vaccine in the late 20th century, following which the number of cases fell dramatically. But it hasn't disappeared. Instead, it shifted into pockets of susceptibility. And so here in the UK, the cases that do occur are sometimes in the older, unvaccinated population. Now, clinically, mumps doesn't always read like our clinical textbooks would suggest. Some patients will have no symptoms at all, whereas others begin with a few days of non-specific features such as fever, headache, malaise, myalgia, and anorexia, and then comes the hallmark feature, parotitis, the classic swelling of the parotid glands, which is present in 95% of people with symptomatic mumps. In my experience, this is usually bilateral, although it can sometimes be unilateral, and patients often describe pain near the angle of their jaw, sometimes worsened by chewing. On examination, you'll see swelling that can distort the face and neck, and the skin there may appear warm and flushed, but there's no associated rash. In more severe cases, this swelling can make it difficult to open the mouth, and reduced salivary flow can lead to mouth dryness. The symptoms usually last a few days, although the course can be uneven. One side may improve while the other actually worsens. And most typically it's the parotid glands that are involved, but occasionally other salivary glands can be affected. Now, from there, we then need to think about complications, because mumps isn't just a glandular disease. And one of the most important of these is orchitis, particularly in post-pubertal males. And this can occur several days after parotitis, although it may present on its own, and this can lead to missed diagnoses. It occurs in up to 38% of infected post-pubertal males, and of these cases, 15 to 30% are bilateral. So patients may again present with systemic symptoms such as fever, chills, and malaise, but now alongside significant testicular pain and swelling, and the scrotum can become edematous, making examination slightly difficult. Now, while this sounds alarming, it's always worth reassuring our patients that subfertility is relatively uncommon, even in bilateral cases, although testicular atrophy later develops in half of affected men, and it is true that decreased sperm count or abnormal sperm morphology arises in about a quarter of patients. It's important to point out there is no evidence for any association between mumps orchitis and testicular cancer. Neurological involvement is also well recognized. Mumps can affect the central nervous system, sometimes without any parotid swelling at all, and meningeal irritation occurs in a notable proportion of patients. And where the CSF is routinely examined with a lumbar puncture, the reported rate is over 50%, but the rate of clinical meningitis is between 1 and 10%. Mumps aseptic meningitis is usually benign, and almost all patients have complete recovery with no residual neurological deficits and no risk of mortality. Mumps encephalitis, however, is much rarer and is a medical emergency, occurring in approximately 0.1 to 0.5% of people with mumps. And it can be a post-infectious complication too, with a mortality rate of 1 to 5%. Other complications include acute pancreatitis, orchitis, and hearing loss. Transient, high-frequency hearing loss occurs in up to 4% of adult men with mumps, and permanent unilateral deafness occurs in approximately 1 in 20,000 cases, although bilateral hearing loss is extremely rare. A wide range of other inflammatory complications affecting joints, kidneys, thyroid, and even the heart have all been described, though these are uncommon. Now, when it comes to the diagnosis, many cases are obviously recognized clinically, particularly during an outbreak with classic parotid swelling. However, in the post-vaccination era, all suspected cases of mumps should be confirmed with laboratory testing, both for accuracy and for public health monitoring. And it's very important to remember here that mumps is a notifiable disease, meaning that suspected or confirmed cases must be reported to public health authorities, because this plays a key role in tracking outbreaks and assessing the effectiveness of vaccines. A white cell count and differential are typically normal, and here in the UK, salivary mumps IgM testing is standard, with the pattern of response and accuracy being very similar to that for serum IgM. Serum IgM testing should not be performed earlier than 3 days following the onset of clinical symptoms, with the ideal timing suggested as 7 to 10 days post-symptom onset. A positive mumps IgM test indicates a very recent infection, and this test will usually remain positive for up to 4 weeks, although false negative results may occur in people with acute mumps infection who have been previously vaccinated. Now, as you might imagine, the differential diagnosis here can be broad, especially when the presentation is atypical, and conditions such as tonsillitis, viral pharyngitis, and infectious mononucleosis can all present with fever and neck swelling. But one useful clinical distinction to remember is that parotid swelling extends from behind the jaw and can't be palpated anteriorly, unlike lymph nodes. Other considerations here include salivary duct obstruction, where the pain typically worsens during meals, and systemic conditions such as HIV. Now, in cases of testicular pain, always exclude torsion urgently, as the consequences of missing this are significant. The management of mumps remains largely supportive, and there's no specific antiviral therapy. So treatment focuses on hydration, analgesia, and symptom relief. So simple measures like paracetamol or ibuprofen are usually sufficient, and in orchitis, rest, scrotal support, and analgesia are the mainstays. But from a public health standpoint, isolation is also very important. So patients should avoid close contact with others for several days after their symptom onset to reduce transmission. And here in the UK, exclusion from school or work is recommended for 5 days. Healthcare professionals with no evidence of mumps immunity who are exposed to patients with mumps should be excluded from duty from the 12th day after first exposure to the 26th day after last exposure. Now, fortunately, the prognosis for mumps is generally excellent. Most patients recover fully within 1 to 2 weeks. And serious complications are uncommon, although they do occur. Mortality is rare, but when it does happen, it's more often seen in adults rather than children. Now, mumps in pregnancy has always raised concerns historically, and there may be a slightly increased risk of miscarriage in early pregnancy, but importantly, the virus is not considered to be teratogenic. So mumps isn't the ubiquitous childhood illness it once was, but it hasn't disappeared. It's just adapted to the gaps in our vaccination coverage and the realities of modern social behaviour. And it can present in subtle or atypical ways, and it still has the potential for significant complications. More importantly, it's a reminder that vaccination programs are only as strong as their coverage. So when that coverage drops, even slightly, diseases such as mumps can re-emerge in very specific and sometimes surprising populations. So the next time you see a patient with facial swelling and a few days of systemic symptoms, it's always worth pausing and asking yourself, could this be mumps? So that's a quick overview of mumps, and I do hope you found this podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which take place all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.